I'd like to welcome Melissa Felteau, who I'm hoping that everybody can see on the screen. So Melissa is our presenter today. Melissa shares her time as the lead meditation therapist and clinical educator with the Rehab Research Group affiliated with Lakehead University in Thunder Bay. Over the past 14 years as a researcher, she has pioneered clinical curriculum and training programs for the delivery of several successful research studies in the neurotrauma field that have used mindfulness-based cognitive therapy. These include a randomized multi-site control trial of mindfulness-based cognitive therapy to treat people with TBI who have depression. Melissa is published in numerous medical journals and has spoken at several international conferences, including the World Congress of Brain Injury in Scotland and Portugal, and most recently at the American Congress of Rehabilitation Medicine. Melissa holds a Master of Education of Adult Education from St. Francis Xavier University. As a longtime meditator, she has studied with John Kabat-Zinn, who popularized mindfulness in medicine, as well as several well-known international meditation teachers. I personally have known Melissa a very long time, as she has served on ONF's Board of Directors for 6 years and ONF's ABI committee for 12 years. We're thrilled to have her be our inaugural webinar speaker. I'd like to pass this over now to Melissa. Thank you for joining us.
Hello, everybody. Good afternoon. I'm so delighted that you're here spending a little time with us this afternoon. So let's start by taking a few minutes right now and use the chat section on your lower right-hand screen and type in what location you're in so that we get an idea who's here. So we'll just take that we'll do that for a couple of minutes if you wouldn't mind. We have Toronto, Sudbury, Ottawa again, more Toronto. Oh, Fredericton, London, Aurora, yay, Ponoka, Alberta, more Sudbury, Oshawa. Oh, Vancouver, welcome. So we have a really nice broad selection of people with us here today. I have no disclosures to report, and our team is very grateful to have our research supported by the Ontario Neurotrauma Foundation. We have a robust research team, including people from Lakehead University, University of Toronto, and University of Ottawa. I am very proud of the devoted group of clinicians who facilitated our groups during the study. In our audience today is Sucheta Hebel from Toronto Rehab, Ellie Nordip, Nancy McCormick, and Evelyn Tan from the Ottawa Hospital. We also wish to express our deep gratitude to all the study participants, many of whom devoted themselves to the practice of mindfulness-based cognitive therapy for traumatic brain injury. Today we'll start by defining mindfulness in the clinical setting, delve into the results of our study and how it was adapted for ABI. We will also explore how this work can be adapted for other populations and the implications for delivery. I'll chat for about 50 minutes and then we'll have lots of time, about 30 minutes, for questions. We have a number of opportunities for interaction through the presentation, so hopefully Angry Birds or your social media accounts will not be my competition today. Let's take our first poll. How many here have some experience with mindfulness practices personally? You have your own meditation practice. Does anybody use mindfulness in their therapy practice? And thirdly, are any of you interested in exploring how mindfulness therapy could benefit your clients? Oh, so we have interesting results coming in already. So we have lots of people with personal experience. Looks like about 88% of the people. And 38% already use it in their therapy practice, and 84% are interested in the client benefit. That's great. So moving to our next interaction, in a moment I'm going to invite you to stare at a candle with your eyes open and with your hand over your mouse and the chart of numbers. Would you please count the number of times your mind wanders off the image of the candle? So I'm going to start a timer here, and we'll do this for about 30 seconds. So we'll start that now, staring at the candle. And each time your mind wanders to a thought, click the square. And stopping and putting your last answers in. Oh, isn't that interesting? So we have about 53% of the people had their mind wander once, 40% had it wander twice, 13% had it wander 3 and 4 times, 6% had it wander 5 times, 20% had it wander 6 times, another almost 6.5% of 7 times, and again, close to 7% had it wander 11 times. Well, you're not alone. We have between 60 and 80,000 thoughts per day. That's one thought every 1.2 seconds. In mindfulness, we are inviting ourselves to witness the constant flow of thoughts, judgments, daydreams, reminiscing, anticipations, emotions, or bodily sensations. And here's the important part: letting them go. Mindfulness is part of emptiness training called shunyata, watching mind phenomena arise and pass away through attention and concentration. For example, you'll see the tendency of the mind to dwell in the past or skip to the future. It's certainly not here. So even right now, can you feel your buttocks on the seat cushion? Your belly rising and falling with each inhalation and each exhalation. Being here means feeling your feet touching the ground, your legs supporting you, holding you upright, your back against the chair, the breath flowing in and out, one after another, the rising and the falling of the breath. Pretty soon you realize your mind has jumped to another thought, and you're no longer here, you're there. Sometimes there, daydreaming for quite some time. And then you take a breath and you remember to come back, and this is mindfulness. Jon Kabat-Zinn says that mindfulness is the awareness that arises by paying attention on purpose and in the present moment, non-judgmentally. Non-judgmentally is key. Not comparing, not criticizing, not deriding yourself for whatever is happening in your life and on the cushion during meditation. We all know that breath is essential. It's the first thing we do when we're born, and it's the last thing we do when we leave. In between, we take approximately 500 million breaths. So why pay attention to the breath? The breath provides a doorway between our consciousness and our conscious and unconscious patterns of thought, and behavior. We may not realize the mind-body breath are intimately connected and can influence each other. In the Pali language, mindfulness of the breath is called anapanasati, and anapati means breath. Sati means bridge between the body and the mind. Our breathing is influenced by our thoughts, and our thoughts and physiology can be influenced by our breath. We've all heard the old example of tigers chasing us on the Serengeti, which drives us into the fight or flight response, raising our respiration, our blood flow, and our hormones to react. So learning to breathe consciously and with awareness can be a valuable tool in helping to restore balance in the mind-body. Despite its current popularity of the last 5 years, mindfulness is a venerable teaching from about 4,000 years ago, from the Great Mindfulness Sutra. There are 4 main foundations of mindfulness, which include mindfulness of the body, of which mindfulness of the breath is part of, mindfulness of feelings, mindfulness of mind, and mindfulness of object of the mind. So we must do the foundational practices first, or mindfulness will be shallow. And mindfulness of the breath, the rising and the falling of the breath in the abdomen, is more grounding. So that becomes a very foundational practice. In 1990, Jon Kabat-Zinn pioneered mindfulness-based stress reduction by removing the Buddhist elements of meditation, but left the Dharma, or the wisdom teachings, to treat patients who had fallen between the cracks and continued to suffer despite medical care. The idea was to develop single-pointed concentration through the practice of meditation, leading to awareness and insight. Siegel, Williams, and Teasdale added a component of cognitive therapy in mindfulness-based cognitive therapy to prevent the relapse of depression in previously remitted patients. And I adapted mindfulness-based cognitive therapy for traumatic brain injury, taking into account the learning accommodations conducive for those with an ABI. This was designed as an adjunct to conventional therapies and for currently depressed patients. So it was really one of the first studies that looked at it as a frontline treatment. So let's take a look at how this might relate to depression and ABI. Depression is the most common axis 1 disorder following traumatic brain injury, with nearly half experiencing post-TBI depression. Adding to the misery, often it's comorbid with anxiety. Depression is the best predictor of psychosocial adjustment, even 10 years post-injury. Understandably, compared to those who are not depressed, individuals with post-TBI depression experience less robust rehab outcomes with greater functional disability and less employment potential. Depression significantly impacts relationships with elevated divorce rates and increased caregiver burden. Understandably, individuals report poorer subjective well-being and poorer quality of life with increased rates of suicidal ideation. It paints a bleak picture and underscores the need to address depression. Can MBCT help people manage the symptoms of depression? The practice of meditation teaches one to sit with and relate differently to whatever might be arising in thought, feelings, and bodily sensations. It helps by slowing down to see one's own thoughts, giving the opportunity to respond differently. By stepping away from unhelpful patterns of thinking associated with chronic sadness and depression. Meditation helps to teach how to befriend difficult moments without the need to distract, avoid, or cover up, while addressing apathy. And very importantly, it teaches one how to see thoughts with non-judgment and compassion, softening negative reactions, and encourages cultivating a tolerance for imperfection and failure. Particularly for people with an ABI, this helps to cope with loss of self and helps to restore a sense of self. So how does this work, you might be thinking? Norman Farb at the Canadian Centre for Mental Health did a very nice study in 2012. He found our regular way of operating is seeing the mind through our narrative mind, the thinking mind. For example, today at work I got so mad when this happened, when that person said this and I did that. That's the kind of narrative thinking. It's the story of me in the key of me. It's the part of the brain that keeps you up at night rolling over every detail that happened. And each time you get out of narrative mind, the thinking mind, the story of me, and come back to the breath, you are building the muscle of mindfulness. Meditation flips you out of the default mode of narrative mind, located in the cerebral cortex, and moves into the lateral cortex, the experiencing mind. Now we're experiencing life unfolding in the now. Now, as John Kabat-Zinn says, this body, this breath, now. The experiential network doesn't get any airtime unless we do mindfulness training. It builds the mindfulness muscle. A word about neuroplasticity. Studies like the 2001 here at the Massachusetts General Hospital with Hoytzel and colleagues are replicating findings with an 8-week mindfulness program similar to the one I'm speaking about today. Their findings demonstrated increases in the hippocampus, important for learning and memory, increases in the cingulate associated with self-awareness, compassion, and introspection, and decreases in the amygdala, which plays an important role in regulating anxiety and stress. So let's look at what we did in our study. The heart of the 10-week program invites participants to practice mindfulness as a way to experience and to develop a different relationship to negative thoughts and fluctuation of mood that occurs in depression. Participants develop a regular practice to develop concentration and awareness. The practices include body scans, sitting meditation, walking meditation, 3-minute breathing spaces, mindful movement, and a process of inquiry and dialogue. So, let's do a short meditation together. It'll just be about 5 minutes or so. And I'll just invite you to get comfortable in your chair with your feet firmly placed on the ground, your hands resting on your thighs, and your head or your ears are level with your shoulders. And you can choose to put your tongue right behind your front teeth in a spot known as fire point. Just relaxes your jaw and completes an energy circuit. And if you wish and feel comfortable closing your eyes, and if not, just gazing about a foot away and down, or your eyes could be half open, half closed. solid, stable, dignified. Now you've taken your seat. Inviting yourself to turn your awareness to your breath. Noticing the gentle rise of an inhalation and the falling of the breath with an exhalation. The simple rising of the breath and falling of the breath. Noticing this either in your chest or in your tummy. Noticing the sensation of the breath rising and falling. As the chest or as the tummy rises and falls, allowing yourself to be cradled by the rhythm of your breath. Much like a mother cradles a baby. Feeling held. Embraced. Comforted by the swing of the breath. There's no place to get to, nothing to change, just breathing. If you find that your mind has wandered off the sensation of the breath, gently note that you've wandered off to thinking mind. Gently escort your attention back to the sensation of breath in your belly. As John Kabat-Zinn says, renewing an acquaintance of an old friend, the breath. Saying hello again and again, each time your mind wanders off the breath, with gentleness, with acceptance, coming back to the sensation of breathing in the belly. Being accompanied by an old friend, trusted companion. This sense of stillness, can be touched at any time just by turning towards the breath, riding the swing of the breath. Enough by David White. Enough. These few words are enough. If not these words, this breath. If not this breath, this sitting here, this opening to the life we have refused again and again until now. Until now. So if you noticed your mind wandering, that's okay. That's what minds do. Success in the practice is not trying to achieve any special state. I like to call it Lake Placid. You're not trying to get to this place where nothing is happening in your brain because, like we saw, we have between 60 and 80,000 thoughts. one every 1.2 seconds. So there's nothing wrong with thinking. The success in the practice is noticing each time the attention is moved off the breath and coming back to it. Very briefly, we'll turn to our randomized control trial. We had 3 centers in Toronto, Ottawa, and Thunder Bay. We used block randomization to intervention or control of 120 participants. The blocking was according to Beck Depression Index scores, age, and gender. Eventually, the controls were crossed over to treatment, and we had 5 treatment waves. The study included those beyond 18 years of age, 1 to 5 years post-traumatic brain injury, of any severity level with insight. We had the usual exclusions, although we allowed and recorded antidepressant use. We assessed for depression and psychological symptoms, changes in attention, memory, and executive functioning, as well as health status, mindfulness, and satisfaction with life. We developed a 6-step clinician training plan that took place over a period of 6 months and 2 years of supervision and support. We started with a 2-day retreat to teach the staff the basics of meditation, the majority of whom had no experience with mindfulness. Over the next 6 months, they met in bi-weekly learning conferences to develop a daily meditation practice and to learn the 10-week program. They then attended a 5-day MBCT training with the original creator, Dr. Siegel. Next, they taught a healthy group to practice their skills, and during this time, we audio taped and video recorded each of their sessions and had an external reviewer administer the MBCT adherence scale for fidelity to the protocol. And finally, we proceeded to 5 waves of the RCT. Prior to this randomized control trial, we had run 3 smaller trials dating back to 2000. I'll just stick to the results of this RCT. Using the Beck Depression Inventory, our study found a statistically significant 26% reduction in overall depression symptoms for the intervention group than the control group. A medium effect size was observed for the Beck Depression Index 2 overall and its subscales. Furthermore, the improvements were maintained at 3-month follow-up. In terms of mindfulness scores, the direction of change in mindfulness was in the hypothesized direction, but did not achieve statistical significance for either the Philadelphia Mindfulness Scale or the Toronto Mindfulness Scale. However, small effect sizes were observed for both the Philadelphia Acceptance and the Toronto Decentering subscales. Most interestingly, we found for those whose depression scores improved, showed a correlation to the increases in mindfulness scores. And lastly, the results were not affected by sight, leading us to believe that our 2-year training program was successful. Let's look at the implications for delivery. And let's check in with another poll. So at this point, do you feel equipped and ready to teach MBCT? And that's a yes or no answer. And oh, that's coming in quite quickly. Oh, sharing or shifting of percentages here. Just wait another couple of seconds. And 23. Oh, no, down to 21. 21 felt equipped to teach MBCT, and that's probably our 4 facilitators that are online right now. That's really good. And 78.9% of you answered that you do not at this point feel equipped and ready to teach MBCT. So thank you for answering that. So when we're thinking about the implications for delivery, we think about 3 things: ethics and training, adaptations, and transferability. My teacher, Zazap Tulko Rinpoche, says mindfulness without discipline, mindfulness without discipline and ethics is like eating salad without dressing. You're missing out on a whole lot. And very simply, if the teacher is not ready, the teaching of mindfulness will be shallow. Here in Canada, we follow the UK practice guidelines, and I encourage you to visit their website because the guidelines are much more robust than the 4 points that I've distilled it down to here. So number 1, they recommend a completion in a rigorous mindfulness-based teacher training program with 12 months of supervision. Number 2, a professional qualification, generally a master's in healthcare, education, social work, or an equivalent life experience. Number 3, most importantly, a daily meditation practice over a sustained period of time. In just strict MBCT trainings, they ask that people have a 2-year meditation practice, and the Center for Mindfulness, where this all started, looks for 5 years of a daily practice. And the 4th point is an annual 7 to 10 day attendance at an annual 7 to 10 day mindfulness meditation residential retreat is required. The delivery of successful outcomes is associated with a longitudinal training program, as we talked about in our clinician training program. You must have a skillful teacher to instruct you in the authentic mindfulness teachings and to guide you in your personal daily meditation practice. The teacher or clinician's embodiment of the key therapeutic ingredients of MBCT and their personal mindfulness practice are essential. Teaching MBCT is not about methodology, but rather it is about embodiment of the 4 heavenly or divine abodes. the possibility of encountering, being with, and befriending experiences with metta or loving kindness, karuna or compassion, equanimity, and sympathetic joy, and being able to model these to the participants. This does not come from a book. It can only be learned experientially and taught experientially. So let's look at the adaptations that we made for MBCT and TBI. Sessions were redesigned to accommodate attention, concentration, memory, and fatigue deficits common following brain injury. Our program has been modified by time, program planning and learning conditions, and learning accommodations. We also focused on making the learning more explicit by fostering critical reflection. Classes were shortened to an hour and a half, but the sessions increased from 8 sessions that are in a normal mindfulness program to 10. Meditations ranged from 3 minutes, 10 minutes, 20, and 30 minutes. Daily home practice included 30-minute meditations. Fostering transformative dimensions is grounded in the learning conditions for learner-centered care. The participants told us trust, non-judgment, compassion, safety, confidentiality, authenticity, acceptance, and support helped build group cohesion, and the group became a place members wanted to belong. Learning accommodations included simplified language, repetition, and visual aids to aid memory and recall. Flexible pacing attended to the needs of the group. If they required more review of a particular topic or theme, facilitators were encouraged to do so. A focus on experiential learning was employed with the use of concrete examples to make the learning more explicit, while the use of symbol, metaphor, and poetry encouraged other ways of knowing. Transfer of learning is key in this population. We reinforce transfer of learning and critical reflection through the use of new learning forms. Self-reflective questions were asked at the end of each session to make learning explicit. Answers were recorded on these carbon-sided forms, with one copy for the participants and one for facilitators. Let's look at transferability to other populations. So using our chat room again, would you please type in the population for which you would be interested in translating MBCT? So we'll just take a minute. And is there any particular clinical population you would be interested in adapting MBCT for? Oh, we're getting some answers now. So, mood disorders, stroke, substance use concerns. We're getting 9. ABI, including MS. Caregivers of ABI patients, that's a good one. Already using it for mild to moderate. Oh, here we go. Now I can read a little more easily. Children, addictions. That's really great. So you can see the utility of MBCT. So if you're familiar with mindfulness, you will know that there's been an explosion of transferability of MBCT to other populations. Our own research team has worked with people in military settings, stroke, and Alzheimer's. Some of our trained teams have moved to offering non-homogeneous groups combining populations. Ottawa Rehab has had great success in running combined groups with ABI and stroke, in both spring and fall, and they carry a very large waiting list. Toronto Rehab Institute are in the process of recruiting and initiating groups for ABI, for people with ABI and MS. And another added benefit of running these kinds of groups is that it's very cost effective. So if you're thinking about how to transfer MBCT to your population, consider the unique characteristics the disability, such as cognitive issues, mobility and safety, and fatigue tolerance. But avoid discussing the disability in group, as MBCT focuses on the impermanence of the moment and wholeness, no matter what condition the body is in. Foster learning conditions suitable for the population and provide accommodations for their particular learning styles. Above all, integrate the disability through fostering self-compassion. I like to say in group, you are whole in this moment, just as you are. The road forward includes publishing our MBCT for traumatic brain injury curriculum. We would like to offer teacher training programs in our program, and we can provide consultation and supervision to programs interested in starting their own program. So our last poll before taking questions is, are you interested in receiving more training in MBCT for ABI? And if you would leave your name and your facility and email, these will not appear on the screen, but we'll have them for future follow-up. So something to ponder about. What are the challenges to incorporating mindfulness into your clinical practice? And secondly, what elements would be essential if a mindfulness initiative was to be developed in your setting? We have published a number of publications, and so they are listed here. A couple pages of our publications. Thank you for your kind attention today. We have about 20-25 minutes for questions. So feel free to type your questions in, and David and Corinne in Toronto will help facilitate those questions, and I'll answer them. So thank you. If you need to click off now, thank you very much for joining us in Ontario Neurotrauma's very first webinar. Do we have any questions?
We have a few people typing, so let's just wait a minute and we'll have a couple.
Okay. Okay. I see a question from Amy Lee. What are some of the outcome measures that are easily accessible and can be used? Oh, they're all flashing in front of me.
Here, do you want me to read it out for you?
Oh, sure. That would be great. How about the first one?
So let's start with the first question is, we have Nikki. So what sort of self-reflective questions would be asked after a meditation session?
Sure. So in the program, they would be listed. The curriculum would list them. But for example, after a session of, let's say we were talking about the 7 attitudes of mindfulness, and they would be asked to reflect on which one of those 7 attitudes of mindfulness could they see as an area that might be problematic in their life. And so they'd be invited to write a little bit about that and then hand that sheet back in. Another kind of question might be, what are you learning about yourself after, like, let's say about, I can't remember if we did it in session 4 or session 6. So people would often answer things like, they realized that they were getting much calmer, that they weren't as reactive as they used to be. So that's all in the curriculum. Okay, David, you want to hit the second question?
All right, so we have the question from Amy Lee. What are some outcome measures that are easily accessible and can be used clinically for ABI population?
Okay, so Amy, I wonder if you can be more specific. Are you looking at depression? Um, you're looking for the kinds of tests that you can use in depression, or more generally? So we'll, oh yes, okay,
Depression,
so yes,
anxiety,
depression
stress.
and stress. Okay, so there there's lots, and what I would suggest you do is we'll be posting this presentation, and you'll get further information where that is. And I would suggest that you read our publication on the results of the randomized control trial, because that goes into all of the standardized tests that we used. Rather than, since I'm not a psychologist, I won't speak to that right now, but it's in our publication. Okay, thank you. David?
Okay, next up we have Wendy. What are some of your thoughts on the training opportunities being offered via the internet and Skype? Is this an option for training moving forward?
That's a very controversial question these days. And my gut feeling has always been you can't really learn effective meditation by the internet. I think it has to be face to face. And I think our clinicians, and they might want to comment on this, when we all got together for our first meditation session, it was in person for 3 days. And then we moved to bi-weekly teleconferences, and it lost a lot of the momentum. I mean, they were really well attended and everyone participated, but it's strange to meditate over the internet. Now, I'll also say, you know, if people are having success, that's great. My teacher, Zazep Tuko Rinpoche, doesn't recommend it either. This just came up at one of our retreats most recently. And he said that there's something very precious about being in person, that it has to do with motivation and really gauging what's going on. Like, I can't see if somebody is starting to lose touch with reality, if and that can happen. You can get meditation psychosis, and that's one of the things we teach our clinicians. So you have to be able to look at those kinds of things. So I would tend to not want to do this on the internet. I think there's components that can be done, but certainly going to a live meditation group in your community would be the first choice. Thank you for that question. David?
All right, next up we have Fanny. Did your research measure the impact of your program on the pain and cognitive troubles related with concussion? If yes, what are your results?
Right, okay. So, yes, we always use a pain analog with our participants, and I don't think it reached statistical significance. So that's a really high degree, especially in a randomized control trial. But in our 3 smaller studies that we did here in Thunder Bay, both with our first group with folks with traumatic brain injury, our second group folks with stroke, and then we did another clinical trial in Ottawa with folks with TBI. Each of the results of those small trials, people their pain was cut in half by doing meditation. What was the other part of that? Okay, pain, and then the cognitive troubles. So in our earlier studies, we didn't measure cognitive function. In the randomized control trial, we did, and none of those results reached statistical significance. So we didn't formally report on those. Good questions. Thank you. Oh, and David is saying the webinar will be uploaded to YouTube. Okay,
So
another
our next
question.
question, yeah, from Karen. Resources are limited for training in many organizations. Do you have any recommendations about how to incorporate mindfulness activities into our work with clients?
Okay. So again, this is another one of those tricky questions because mindfulness is so popular and it's seen to be quite useful and successful in achieving results. But that's in a how do I want to say, in a formal week by week setting, using it every single time, and the facilitators are quite highly trained people. So we do not have any studies showing the efficacy of mindfulness in just using it as a little adjunct every once in a while. And I think there's some, I think there's some danger of the teachings being watered down. So my preference is to see, real programs of mindfulness-based cognitive therapy or mindfulness-based stress reduction done. That's not to say that if you're trained that you can weave it into your regular practice. So I'm staying away from telling people what to do in their practices if you're not trained. And the next question?
From Ellie, what are your thoughts on teaching MBCT curriculum on an individual basis with clients?
I think that's a great way to work with people. Groups have thank you, Ellie. Groups have their own special dynamic, and you'll see clients changing partially from their practice and partially from the group dynamic, what's happening and how that supports their growth and recovery. In individual practice, I see great results with people, and if you're trained, I highly recommend that you do that.
Our next question is from Lauren. Did you use the river meet?
No, we did not. We have another question coming. We can also talk about what you noticed during your meditation. If you have any questions when we did our own mindfulness of the breath meditation, if you wanted to report on that. Okay, here's Sucheda's question.
Do you have any comments on single facilitator versus dual facilitator model of facilitating an MBCT program?
Mm-hmm. So, I think it's whatever the facility can manage at that time, Sucheda. Thanks for your question. If the facilitator is highly trained and is used to running groups by themselves, then I think that's a good thing to do. I think it's preferable to have two co-facilitators. There's benefit of the synergies working together when you really partner with your co-facilitator. But it can be done. It certainly can be done. Certainly in our research study, let me think. The first two smaller trials that we did, there was two therapists, myself and another therapist, but I was the only one trained, so I was teaching the meditation specifically. And in the Ottawa trial, the single trial, I was the only facilitator. I had a dropout. So it can be done. It's a lot of work. You need to be really focused. That's why you need your own meditation practice, nice and strong.
So at this point, I think that there aren't any more questions, but there might be in the next 5 or 10 minutes, in the next few days. So, Melissa, if you're willing to have us forward any questions to you, we can do that. If everybody would respond to David and David at onf.ca and sorry, excuse me, David at onf.org. And just let him know if you have any questions, and we can forward those to Melissa. I really want to thank David, who was our behind-the-scenes man, who helped organize the presentation, and once again, just tremendous thank you to Melissa Felteau, who has been a real guiding light in the area of meditation and TBI. And we want to thank you for your time, and for all of you for listening in. We're going to end off now. Thank you.
Thanks, everybody.